Take it away.
Thank you so much for having us and allowing me to come speak and present on this. This is a great topic that we're really excited about, and it's something that really, I guess, one of the main reasons why we're excited about it is because when you look at treatment and all the treatment options, that's kind of after the fact, and being able to have something that's starting to focus on sort of mindful prevention, that's person driven, it's wonderful to have some of that option that we can kind of talk about. So what I wanted to do was just kind of go over some learning objectives for the evening. I think for our time together, what we want to do is define what the sober curious movement is and why it matters from a harm reduction lens. We also want to talk a little bit about what the benefits of reducing or reevaluating substance use, especially alcohol post-COVID. We can talk about some statistics we're seeing here in the field, and also how to start to recognize when a behavior might be moving beyond just partying or just maybe doing some hard drinking here and there on the weekends, and when it starts to then also become maybe a problematic pattern or even into disordered behavior, and understanding some of the key diagnostic features of what substance use disorder is and how that not just develops over time with like tolerance or reliance or erosion of coping skills, um, but also what's the difference between that and maybe just drinking a lot. Those can be some sort of subtle distinctions, and also explore some recovery and treatment options for if someone were to maybe identify, I'm kind of past where the prevention point is, and now the problem is maybe more biologically involved or has some neurochemistry involved, or might even put me at some significant health risks if I were to try to stop on my own. So being able to distinguish all of those things, I think, is really important as well. So let's jump right into it. When we start looking at the sober curious movement, this was something that started, I think, officially with the publication of the book Sober Curious in 2018 by Ruby Warrington. Since then, a lot of people have appropriated the term, because it's just a great term, and it's this idea that people can start to intentionally question or change someone's relationship with alcohol or other substances without necessarily committing to lifelong abstinence. And I think that all or nothing sense is something that is really a big challenge for people looking to address what might become problematic. I don't know about all of you in the audience, but for me, the thought of having to commit 100% to anything forever, all at once, that's a lot to wrap someone's arm around. And I don't care if that's like remembering to floss or eating healthy or starting to exercise. I think that's just part of something that we all share as human beings, that making these forever decisions is just very daunting and usually has kind of the opposite effect of, well, we'll maybe get to that next week. It's a busy week. And so this idea of getting ahead of that by starting to make some behavioral changes that don't necessarily commit to lifelong abstinence. And what that does is that really aligns with a lot of what we see in the in harm reduction, which is a huge movement, and that's leaning a little bit more towards prevention. Um, because the last thing we want to do is alienate someone who's looking towards making some positive changes, and then having them sort of say, well, maybe this is too much, or I can't really do that. And it emphasizes mindfulness. And by mindfulness, I mean sort of having a self-awareness, having a situational awareness. Why am I drinking? How do I feel when I do? What does it do for me? What does it do to me? For many, it means reduction or taking breaks. We've seen these things like dry January or no drinking November, or however people want to pitch it, but it's these ideas of drinking less frequently, less intensely. And it also represents a cultural shift. There are some studies that pointed out that younger generations like Gen Z or millennials are actually more likely to reduce or question alcohol than some earlier generations. And this idea of reducing risk, improving well-being, meeting people where they are, rather than insisting on full abstinence from the outset, is something that we've seen to be very effective in the field when employed at the appropriate time. And that generally would mean earlier. And so when you look at what are the benefits of engaging in some of this sober curious um, reduction, is there's a lot. It leads to improved physical health. Generally, less alcohol means fewer calories, less strain on the liver, reduced risks of accidents and chronic disease. A lot of this was highlighted by Penn Medicine. Better mental and emotional well-being. And when we talk about not just reduced anxiety or better sleep or improved mood, it's just this general sense of feeling a little bit better regulated. One thing we're going to talk a little bit later on is the fact that if people are engaging in what we refer to as self-medication, which is kind of self-explanatory. It's this idea where I feel anxious or I'm stressed, or I mean, think of how many times you've heard someone say, "Oh, what a tough week," or "Our work was brutal. I could really use a drink," or "Having a drink would help me relax," or even just people who are maybe dipping into some other substances. It generally serves some type of purpose initially, especially. And so when we look at this idea of relying on a substance to self-regulate, couple of things happen experientially as well as neurologically. It tends to start to very quickly erode other people's natural and normal coping skills, and there becomes sort of a psychological or emotional or even chemical reliance um, on these substances to do that for the individual. So that makes it a little challenging, and it's think of it like standing on a slide. It generally is going to drift in a specific direction when we start leaning into these substances that do things for us, but in a lot of ways it can force our brains to produce more of certain chemicals than it ever would on its own. And that feels great at the time, but the downstream effect of that is that it's sort of like messing with a thermostat. Not right away, but over time, when you string enough of these together, it could start to kind of hit critical mass. And we'll talk a little bit about that shortly. So, uh, just this idea of reducing the frequency, quantity of more intense utilization of any of these substances, we really lower the chance of progression towards more serious problems. And that also includes taking breaks. Um, so when we talk about this sober curious pathway functioning as a harm reduction strategy, um, it really is an excellent choice for some people to question it. And I have to point out, just the fact that someone is taking a look and looking at their substance use through the lens of how does this serve me? Is this creating any consequences? Am I starting to, because when you speak to pretty much anyone that comes to our programs as a patient, there was a period of time when there was some clarity and they were looking at things objectively and sort of saying, this kind of doesn't feel right, or I know I'm leaning into this a little bit, but it's just for now. And again, if you ask someone who develops substance use disorder, which drink or which night of hard using tipped the scales to substance use disorder? At what point did we turn from I'm drinking a lot to now I'm diagnosed with a substance use disorder and my body reacts poorly when it happens? Which drink was that? It's not always that easy. And it's similar to asking a question, well, which breath, if I breathe into a balloon and I keep blowing up a balloon until it pops, which breath caused it to pop? Well, the simplistic answer is, well, it's the last one. Well, if you think about it, it's actually all of them. It's all of them combined over that period of time without any chance to sort of release that. So there's this collective build to critical mass that we really want to think of when we're looking at this. So the idea of reducing not just frequency but consistency, all of that's really positive and tied into that um, sober curious. So um, when we look at some of these things, um, this kind of summarizes a little bit about um, what we're talking about here. The link between harm reduction and sober curious, where the overlaps are, is it encourages the mindful change. It's non-judgmental. And for those of you who are joining because you may be concerned about a loved one that you maybe see using substances more often or kind of developing a problematic pattern of use, it's really important when we engage with people that it's non-judgmental, it feels supportive. Why questions always kind of carry that judgment. Um, so this is really kind of how we want to approach it. Now, these are some practical strategies when we start looking at this. Um, the way these things can sort of change over time, we talked about, but right away, let's go through some of these boxes. So The easiest thing is to sort of choose some no drink days. I'm going to talk about this from two sides of a coin. Obviously, if someone is recognizing, you know what, I went from drinking on the weekends or using on the here and there when I'm partying to now I'm kind of every day there's a reason, there's an excuse. I'm telling myself kind of a story or creating this narrative about why I'm drinking more. Actively and intentionally choosing not to drink kind of breaks that cycle up to where we're going to build up to the point where the body's going to become maybe tissue dependent. Um, that's helpful. The other side of that, and this is kind of a symptom of where we start to actually identify and define this as a disordered behavior, is if someone starts making these we can call it failed negotiations. Someone starts to say to themselves, you know what, that's it. I'm only drinking on the weekends. No more drinking towards the weekdays. I was hungover, had trouble getting to work. All these things, it's getting a little weird. And then by Tuesday night, we're back to drinking. That could be a real indication that things are kind of moving in a different direction. Because the problem with that is when we see ourselves start to consistently move the finish line further and further back, and it's sort of like, well, you cross this line, it's a problem. And then we kind of step over it ourselves. Well, we just kind of move the line. As long as I'm not crossing over this line, that can kind of repeat until we walk ourselves right over the edge. So these consistently moving goalposts is kind of a big red flag. But if we're able to do that and we're able to sort of mitigate that, reel it back in before it becomes problematic, um, that's always very helpful. Tracking use and triggers, and so a lot of the times stress. When we see the tremendous ramp up of alcohol use disorder post COVID, there are a lot of factors there, and part of what we looked at when we studied it was this idea that it's social isolation. It was the anxiety. It was people being disconnected from their routine. It was people from being disconnected from things that were meaningful to them, including people and family and all of those types of things. Those are the types of things that contribute to the development of substance use disorder. Because you have to understand, substance use disorder, there's the neurophysical piece to it, but there's also the social element, the emotional element, the cognitive thinking piece, and the rationalization piece, and all of these things kind of align to create what we describe as substance use disorder. And when you look at treating or addressing it or even preventing it, you really want to start looking at all of those domains as well. So part of this um, can can be the idea that when do I find myself either wanting a drink or finding it very easy to talk myself into maybe having two or three drinks, or if usually I have one with dinner, but then I find myself like look back. And a lot of that is check in the rearview mirror to sort of say, what was going on the last 24, 48 hours? And when people start to look at this in a mindful way and zoom out, you'll be amazed at people's capacity to start to see what actually triggers them. Something could be even, every time I go visit my mom or I talk to my dad or I get into an argument with my sister, I find that, I'm saying, you know what, this was it. What a terrible day. I'm going to have a drink to relax. And that's always the reason. But knowing what our triggers are helps us understand where we're maybe a little bit vulnerable. And even an upside to that is maybe where we need to do a little bit of work to shore up some of our natural coping skills. Um, and that's pretty much it. Try non-alcohol alternatives. I don't know if those of you have gone out and seen a lot of these places have developed these very elaborate and pretty amazing mocktail menus. And for those of you that haven't tried them, I would encourage you. It's even if you're just out and about and want to sort of mark a special occasion, some of these they're very elaborate, they're very well thought out. There's a lot of different flavor palettes, and for people who are kind of maybe used to running with people who drink a lot, they look like actual cocktails. So it's a lot less awkward to sort of be maintaining sobriety or reducing drinking if you're with people that are drinking, which I mean that's its own sort of set of things to look at, but it's a way to sort of have something in your hand that looks like a cocktail, that tastes amazing, that's got that celebratory feel to it. It makes things kind of easier. We were speaking with one patient who was sort of rationalizing very significant patterns of relapse by the need to drink at work functions. Well, I don't want to insult someone if they don't bring me if they, if they bring me a drink, I don't want to refuse it. I don't want to over explain it. I said, well, just make sure there's always something in your hand. Get ginger ale with lime. And frankly, if you have people like leaning over and smelling your drink or asking you what you're drinking and pushing the issue, that's kind of its own set of issues. So, and it worked. He's like, hey, you know what? I always just had something that looked like a drink. I was fine. Everyone was fine. Keep it moving. It also helps to build coping skills in the sense that when you look at a behavior of compulsion, right, and that buildup of trying to resist something where there's maybe an urge to it, or um, a push of like an inner dialogue, or urges, or intrusive thoughts about something, and we're resisting it. When we give into it, there's that release, there, that relief, and that actually makes us less likely and capable to do it the next time. And at the same time, when we look at our capacity to use our natural coping skills to resist the urge to just sort of go down that route of just saying, well, whatever, I'm just going to try, I don't care, it doesn't matter, or just, if we're able to kind of even white knuckle it and get through that, we kind of have that little pebble of confidence to sort of say, look, if I really needed to, I could pump the brakes on this. It's okay. Versus constantly just sort of saying, well, whatever, next week I'll really get started, as I can't really get into this week because, reasons. Um, that's choosing that direction. It's like anything. It's like sitting on the couch, right? We're going to relax, but it's tough feeling out of shape. Saving money is hard. So is being broke. It's, generally both things are difficult. It's just a question of, do we front load the discomfort to build things that are fulfilling and resilient? Or do we sort of front load the comfort and then really find ourselves having a really hard time with some of the basics sometimes? Sober social activities, a lot of times there's more and more and more, whether it's on like meetup.com or any type of, it's so easy to find some of these things online too. A lot of the event-driven things are now sober, so a lot more access to these things, and they're sober without necessarily needing to be tied to something formal. And then the idea of just reevaluating regularly. It's really about looking in the mirror and having that honest conversation of saying, well, how am I doing, and what do I want to do about it? And that's essentially kind of, I would say, the harm reduction, strategic, what can I do and what does it look like approach. Now, when we look at how substance use progresses, there's this idea of social use where it's sort of occasional, it's event based, it's maybe when I'm around certain people or when we're at certain parties or those types of things. And generally, there are plenty of people that are able to maintain that. One of the markers of that is the fact that there's no cravings, there's no tolerance. You think of the people who kind of have a glass of wine with dinner for their entire adult life and don't have those problems. You contrast that with someone who, when they start drinking, they generally, they may wind up in booking by at 2 in the morning, almost every time, and say, I don't know why this always happens. When you start looking at risky use, that's really something that is maybe something like socially maybe becoming impaired, where we're doing and saying things that are a little embarrassing or socially inconvenient. Um, Ramp that up now to maybe drinking too much and we're having trouble getting to work or meeting some of our obligations here and there. We're spending a lot of time maybe recovering from that use. Risky use can graduate into maybe drinking in areas where it becomes a safety risk if we're buzzed and driving home anyway, or those types of things. And that's sort of where we start. Those are sort of the different levels of risky use. When we start talking about problematic, that's when it's kind of over time. Problematic use is really characterized where now there's significant absenteeism. Now maybe my closest relationships are sort of saying, I'm not comfortable with either how often you're drinking or using, or how you are when you're drinking or using, or something's just off. People are calling it out. And then when we get into substance use disorder, when it becomes that true sort of substance use disorder, that's what we're going to talk about now. And there's some important characteristics there that lend itself to disordered behavior. And the reason why I want to take the time to do this is there's prevention and there's treatment. and they're kind of on different continuums, because if you're able to successfully prevent something, that's best case scenario. Why? Well, now there's nothing to treat. We have avoided that. It's, do we want to treat and recover from a heart attack, or do we want to prevent a heart attack? Obviously, that model plays to pretty much anything that could be. Um, and when you look at some of the statistics for substance use disorder, and what it's costing families, and all of the opioid fatalities, prevention is something we can certainly do a much better job of. And from speaking with people in the field, I think that's, collectively, there are a lot of people who are like, we really want to get ahead of this. um, we're always here to help support and help people get back on track. But imagine how amazing it could be if we could also start to bolster that with some prevention, so that people never had to sort of get all the way down to the bottom of the slide where they're really picking up the pieces at that point, if they make it in some cases. So when we start looking at what characterizes something that's maybe gone past the point of where prevention is feasible, or even possible, the reason why it's so important to know that distinction is, if I've developed a physical tolerance and a physical dependence to something, and this is where we start to characterize addiction versus maybe problematic patterns of use, or overuse, or misuse, or however else we want to characterize it. If I have that physical dependence and tolerance, there are certain substances where, if I try to abruptly reduce or stop that use, I'm going to have an extreme physical reaction, some of which can actually be fatal. And many people don't know that alcohol is actually one of the most dangerous withdrawals that someone could have. It could result in a seizure, and it could be fatal as well. There's the delirium tremens, which are, very, very severe presentation, that's high risk, that some people may not come out of either. So, a couple of things that we're going to review, and this is kind of how this works. So when we start talking about addiction, this is how it affects the brain. We're not going to get into major neuroscience, but we're going to do a very quick top level view here. When you think of addictive substances, and this is whether it's, cocaine, opioids, fentanyl, heroin, alcohol, whatever the case is, overall, they're generally going to overload the brain's reward system. In a lot of cases, that's with dopamine. Now, this creates a powerful urge to repeat the behavior. And there's the neurochemistry behind it, but experientially, what a lot of people feel is, they just they're thinking about it. Oh, I can't wait to get off work and have that drink. Or, maybe when I have some time to myself, I'm really looking forward to relaxing. And that can ramp up, and also lead to sort of these strong urges. They can become physical urges. It becomes very difficult and very distracting. So the natural pleasure responses diminish over time, tolerance builds. And that's why, when you start hearing about patients who are coming in, and they maybe started misusing some prescription, and now they're using 25, 35, 50 bags of fentanyl a day, that didn't happen overnight. And what happens is, tolerance is essentially defined as needing more of the same substance to get the same effect, as well as not kind of receiving the same result when we take the same amount. So the idea that maybe someone could gear down or relax with one beer, or one glass of wine, or one mixed drink, and that just doesn't cut it. And it's transitions to the point where now people are drinking, by the time patients get to us here in withdrawal management, they may be drinking 2, 3 pints, 2, 3 liters, an entire handle a day. And they describe it as just like a full-time job from the time they wake up. And when addiction changes these areas of the brain, it also can impact judgment and impulse. All of these types of things, like motivation, emotion, and behavior, all of these things are impacted. And it becomes more and more challenging to resist these cravings, or even in some cases, look at long-term consequences. One of the things that could happen is that we start looking at how the reaction to not having the substance can start to hijack someone's fight or flight response. And as we all know, when we're panicky and we're feeling that high level of anxiety, well, a lot of times we aren't necessarily thinking rationally. And it's more focused on, directed towards getting rid of that feeling. And a lot of times people are like, I can't deal with this right now. I just gotta go. I'll figure it out later. And substance use disorder, one of the markers is that people will continue to use substances despite persistent negative consequences that they know are a direct result of those substances. That's, again, it's a disordered behavior. People are consistently acting against their self-interest there. So how will I know if it's a problem? This is a question we get asked a lot. These are essentially the 11 criteria in the DSM-5, which is the manual that um, psychiatrists and people in the mental health field use to identify what's the difference between someone who's clinically depressed and someone who's maybe just feeling sad or down or having a hard time. This is how we define substance use disorder. And so when we know it's a problem, it's if you meet two of these criteria within a 12-month period, that could be an indication of at least maybe the mild or the onset of a substance use disorder. And it's mix and match here. So it's not that any two specific ones are necessary. And obviously the more criteria that you meet, the more severe the substance use disorder is. And so when we talk about neglecting major roles, that's when we start getting into we're not going to work, we're making promises to go take the kids somewhere and we're too hungover to do it. We talked a little bit about tolerance. The larger amounts, that's when we start getting into that negotiating. I'm only going to have one drink, and the next thing you know, we're blacking out, or we've gone through the whole six-pack or the whole bottle or the whole case. The repeated attempts to control use or to quit. This is why the sober, curious movement can be so valuable from a prevention standpoint, because, and I can share a little bit of a story here. In another part of my career, I was working with adolescents in a cannabis, well, it was a substance use disorder treatment. It was outpatient. It was primarily cannabis. And so there was a lot of minimizing and rationalizing by the patients. And not to mention the adolescent bravado. Those of you who have adolescents and have worked with adolescents know that, it's the risks are really not really, I'll figure it out later. It's going to be fine. Whatever, you don't know what you're talking about. That's a real thing. And so it was very common for the patients to sort of say, this isn't a big deal. It's just weed. I can stop whenever I want. And for those of you that have adolescents, if we were to sort of say, no, you can't, here's all the science and let me prove you wrong, how would that conversation go? Probably not so well. And as a matter of fact, what we found in the field is that we know now, and it's evidence-based, that resistance and confrontation actually increases resistance and reduces the likelihood that someone's going to move towards positive change. So what we did is we just kind of rolled with that resistance, said, okay, I believe you. Try it. If weed is such a minimal problem and every adult in your life is overreacting, don't smoke for a week and come back and you let me know how easy that was. And that did a number of things. The patient sometimes would walk out of this with, well, I'll show you. And if that's what led to the sobriety, well, so be it. But they at least gave it a shot. And ultimately, if I tell someone that they have a problem, well, we'll see about that. I don't know. And then now we're back and forth with playing yeah, but if I ask someone to explore if they had a problem and they find that it's harder than they thought it was, well, now they've got their own full attention. And they're going to start asking a lot more questions like, how far down the slide have I really kind of gone? Or am I telling myself it's very uncomfortable? And it creates some of this sort of dissonance with like, well, I thought it was this. And people are either going to double down on the rationalizing, which is not optimal, or they're going to sort of say, well, I really kind of got to get ahead of this. This is a critical window for someone to either kind of, for lack of a better term, just kind of hide under the covers and sort of use hope as a strategy and say, well, I'll figure it out later. You string enough of those down the line, now they're a patient in a substance use disorder program, versus sort of saying, I'm not comfortable with this, but I don't know what to do. This is the time to pair someone with someone who can help them ask those questions. Our job as addictions professional, believe it or not, is not to sit here and tell anyone what to do. Anyone that suffered the consequences of addiction knows they want out and that this is not the lifestyle that they want. It's very uncomfortable. There's a lot of guilt and shame. It's a lot of work. Um, and it's generally sort of descending into disaster. Most people wouldn't sign up for that, you know? Um, that being said, the way out isn't always that obvious or apparent. And helping someone, empowering someone to help them ask those questions and play what now, that's where we can really sort of turn the ship here and start pulling back from some of this, as well as giving a chance to sort of develop some if-then strategies for what if I do have cravings? What if I am triggered? What if I am having a hard time and I'm stressed and tired and hungry and have an argument with someone that really, gets under my skin, and that part of my brain that's now kind of compromised is like, I'm going to pull the fire alarm because we're running way too hot. We can't have that. So let's just kind of cool this off. Um, we need to kind of get ahead of this. So this is a critical window, and this would be a time to, for anyone listening who's experiencing that, or anyone whose family member or loved one comes to you and it's like, I don't know what to do. That's a hot potato, right? And those of us who, because prior to becoming addictions professionals, we were not, we may have had family members come up and say, I don't know what to do. And sometimes we're like, well, I don't either. And so knowing kind of where to go and how to get those answers and how to get that person in front of the right people who are going to guide them and make them feel supported and empowered to make those changes, that's a big deal. Okay. And so for those of you who have chosen to attend this either for yourselves or your loved ones, I know we kind of took the long way around the lake with some of this stuff, but that's why. And this idea of repeated attempts to control, use, or quit, one of the best things about the sober, curious movement is it puts people and I say people because every patient before they were a patient was a person. There still are, but it allows people to sort of get ahead of themselves and really spotlight some of this behavior for themselves before they become a patient. And now they're sort of crawling up against neurochemistry and some of that, which makes it a lot more challenging. So so when to consider treatment? If any attempts at reduction doesn't work, um, or any of those symptoms are present, especially withdrawal. And I'll tell you this much: if someone is drinking alcohol and they find that their hands are shaking in the mornings, or if they haven't, if they've gone, 4 to 8 hours without having a drink and they start sweating, their heart rate goes up. They may start getting red faced. They feel sick to their stomach or vomit. Any of those types of withdrawal behaviors, that is a big red button, call 911 scenario, because those types of things are all of that neural activity ramping back up. And if it hits a certain point, that could result in that seizure. So alcohol withdrawal is that is a medical emergency. I cannot emphasize that enough. Opioid withdrawal, that's something also that requires inpatient hospital stay. That's got the nausea, diarrhea, sweating, chills, aches, pains, cravings and urges, all of those types of things. Anxiety for both. Anxiety sends more people back out to the street doctor or the liquor store than anybody, because that can really get that panic going, where now we're sort of shutting down that rational thought and losing our coping skills there too. So that withdrawal, if we're seeing some of that, that's definitely treatment time. Benzodiazepines as well. Benzos are something similar to like Valium or Xanax or Klonopin, or those types of medications frequently prescribed for anxiety. Some people, if they're misusing them, start to have a rebound effect, and that's very easy to sort of, well, that's why I need more, is because I feel so anxious and it's the only thing that helps me relax. Well, that can sort of spiral down into some pretty serious use. So any of those things start to show up, that's when they want to consider therapy. Could be in a group, could be individual therapy. And the two things here, CBT and MI, those are the two modalities to look for. That's cognitive behavioral therapy or motivational interviewing. It's kind of a weird term, but that's helping motivational interviewing is really meeting a patient where they're at and helping them sort of ask those questions to move through the stages of change, from sort of working on putting a lot of effort into denying there's a problem, into maybe starting to use what we call change talk and exploring, well, what can I do? Those are both very helpful for people in the early stages of recovery. Peer support is huge. Peer recovery specialists is a modality that New Jersey has really embraced. And that's where the difference between a clinician and a peer recovery specialist, the peer specialist can sort of take a knee and say, listen, I've been in that bed in the hospital. I've wanted to leave my program and just go back to use. I've wanted to give up, and this is what helped me. Whereas clinicians really have kind of that um, I guess for lack of a better word, kind of clinical distance, just in the same way where you go to your doctor, they're not going to pull out their x-rays and say, oh man, look at my knee, right? That would be a little odd. That's more of a treatment thing. The peers, they fill that gap by being able to share their lived experience. And that's something can kind of really connect with someone who's struggling. Medication assisted treatment. There's a number of medications. That's a whole nother separate talk we could give. But medication assisted treatment refers to medications that um, help sort of work on those receptors to reduce cravings and help people manage. Um, they range from what's called, and I don't want to get too technical here, like a full agonist like methadone that gives kind of a full effect and then you're replacing it, to things that maybe are some synthetics that just kind of give a partial effect and bind on those receptors and sit on there to help manage those cravings, to some that give no effect and they're just a blocker. So there's a lot of options. A lot of technology has been invested in developing these medications. There's a whole back and forth about if someone's using those medications, are they really sober? Those of us in the treatment field, the majority of us feel that they are, because what we look at is if someone's taking a medication once a day or twice a day and they're out there living their lives and they no longer really meet any of these criteria for substance use disorder, well, guess what? They no longer meet criteria for substance use disorder. They're in remission. But that's a whole nother topic, but that's an option out there. And there's a lot of outpatient and inpatient treatment programs. It's mentioned withdrawal management may be required. We can't just send someone to treatment if they're going to be there in day 2 or 3. They're going to be having seizures or being violently ill due to the withdrawal. So they might need to go in. That's done in a hospital, like our unit here. So here's a quick summary, a call to action. Sober Curious. It's that mindful harm reduction approach. The best things to do are to look to make small changes that have a big impact. Again, reducing that chronicity or that time between drinks, that can really start to help, especially if it's longer durations. Those are going to help rebuild coping skills, help people reconnect. Because over time, if I'm going to skip a day of drinking, or a patient skips a day of drinking, that's not going to do too much because these are patterns that build up over time. And they really say that it takes between 90 days and a year for someone's brain chemistry to really re-regulate in early recovery. So the longer someone is able to practice or create these sort of pockets of abstinence without necessarily committing to, I'm never going to drink or use again, the more likely they are to start to kind of come back to themselves. That fog will start to kind of lift. The health benefits will start to show up. So small changes, big impact. And we're talking about habits. We're talking about patterns of behavior. We're also talking about mindset. So none of that's going to happen without self-reflection or without having some structure imposed on that. And again, remember that pivotal point of, if I make a deal that I'm not going to drink this week, or I'm only drinking on the weekends, and I'm 40 hours later, I'm back at it, it's probably time to talk to somebody. Screening and treatment, talk to a professional. This is actually, interestingly enough, someone who's not sure or scared or whatever the case is, they may go into a screening in their mind to rule it out and say, well, let me just talk. I'm sure I don't have a problem. Let me talk to someone and just, hey, talk to a professional. Let them tell you don't have a problem. A lot of times people might resist it if they're afraid that they do. Some people might say, okay, well, let me rule it out. Let me be confident. And then by going through that assessment, they find out, well, this is maybe a little more intense than I thought. So, and starting now, right? What can we do? And this is a question we ask a lot of our patients sometimes. What are you ready, willing, and able to do right now? Right? Not next week, not in a month, not when your bank account's where it needs to be and your boss calms down and you have the perfect run. And it's right now. What are you ready, willing, and able to do? Because if we can get something started, we're at least pausing the drift into development of something worse, or building tolerance, and we can at least catch our breath and reevaluate. So I'm going to take just a minute to talk a little bit about our unit and what we do and kind of why this is so important for us. Valley Hospital is committed to providing care like no other to our communities. And during COVID, we really realized that substance use disorder, especially alcohol use disorder, was a significant problem in the community. Our community health needs assessments reflect that, and Valley wanted to be there for our communities to be able to provide this service as well. So we're a specialty unit. It's not like the main hospital. Majority of our rooms are single rooms. We've converted some rooms into where we can provide group and individual therapy and some social work. So it is a medical process. We are a med-surg unit, really equipped to deal with very severe presentations and additional health complications on our unit. And in addition to that, if you were to just take someone with substance use disorder and have them sit in a bed for 3 to 7 days waiting for medication, that's not a recipe for someone to feel good about treatment. So what we do is we have a specialized multidisciplinary team with duly licensed clinicians. I'm a licensed clinical social worker and a licensed certified alcohol and drug counselor, a program coordinator, and a number of other staff are. We're able to consistently work with the patients. All of our nurses are very, very well versed in treating all of the symptoms of withdrawal. And this integrated team is really what creates this specialized therapeutic environment. We don't have visitors here because that could either reduce contraband or start arguments. It's a chance for the patients to be in that sort of very serene environment where they can focus on themselves and their recovery. We also provide a lot of holistic therapies. We have pet therapy that comes through here. We do some mindfulness meditation. We can also provide clinical application of essential oils. A lot of these things, anything to maintain motivation and engagement. And what we do is everybody is given a personalized aftercare. We don't treat every single patient the same. And so what that looks like in terms of how do we specialize our interventions, our medical director has created a very refined, specific order set and protocols, not just to manage the primary withdrawal, but a lot of these symptoms that can show up, excuse the reference, like whack-a-mole. It's just everything's fine and then things are just popping up all the time. There are medications to really kind of handle all these things as they pop up. And every patient gets a full biopsychosocial assessment. We're going to do kind of a deep history. What this does is this drives that treatment planning aspect. And we also really want to look at sorry for the clinical terms here, but when we look at bilateral influences, is the whole idea of like, how is addiction affecting my social domains of my life and my relationships? And how is the dysfunction in my relationships really sort of amping up my substance use? And how can we make some changes now? And we look at all of those different life domains beyond the medical, and we have time to do that here. And we're going to make, in addition to using the evidence-based practices, we're going to make a very personalized recommendation for someone for how they can start to make some changes. And it's really based, if you think about it, our patient, they're probably one of the most important people on the treatment team because they're the ones that are the experts on themselves. They know what they're ready, willing, and able and capable of doing right now. And so it's really important that we build that rapport and engage them in the treatment planning process because if all we do is treat the physical symptoms and then put them back in the same environment with the same stressors and the same relationships, and what do we think is going to happen? So we really want to start talking about planning for change and meeting them where they're at, getting them started. And that's what we do here in our unit. So now we don't use a call center. This number that I put up on here, if you were to call that number right now, it's going to ring just on the other side of this door, and a member of our treatment team is going to be able to pick that up, which is amazing because we can build that rapport and make a connection with the patient, even if they just want information. We get a lot of family members calling. My daughter is doing this, my son is doing that, my husband is XYZ. I don't know what to do. Ultimately, what we want to do is facilitate so that we can speak to them, help them ask the right questions, let them know what their options are. And if they do decide that they need to come with us, we can get them started on that. If they don't need to come with us, we can get them linked up with resources in the community. We can even do that with family members too. So if for whatever reason, as we said, people are looking at this sober curious, because as an addictions counselor, especially working in a medical situation, I have to make sure that we're cautioning everyone listening to this, that if you yourself or someone you know is going to try this sober curious, if they're far enough down the road, they could be setting themselves up for a medical emergency. It is essential that if you see that withdrawal going, or any of those symptoms, that you call 911 or get yourself to the emergency room right away so that that can be addressed. But if it's really kind of very early in that process, Sober Curious is a wonderful opportunity for harm reduction, and a wonderful chance for people to really reflect on how they're using substances, what it's doing for them, what it's doing to them, or could be doing to them, and is it really what they want to do, and how they want to choose to sort of relax, self-regulate, etc. There's a ton more information on our landing page on the website too. If you go to valleyhealth.com/recovery, there's videos, there's a patient manual, there's we have a blog, there's some podcast recordings.